Well, thank you very much for having me. And I hope that in the next 45 minutes that I'm going to give you a little bit of insight into what we do at Mayo Clinic and a little bit of the philosophy of our lab and try and explain the reasons why we are building very comprehensive and complex autoimmune neurology evaluations. I'm going to be focusing on encephalopathy and epilepsy. I understand that there are some interest in some of the newer tests for MS, a test that potentially could replace autosomal bands, and I'm certainly going to be happy to address those questions. Hopefully I'll leave 15 minutes at the end if any questions arise. So just to share with you my disclosures. So I'm a salaried consultant at Mayo. If you order 1,000 tests or you order 500,000 tests, it makes no difference. I'm salaried. I don't get any percent of any profit, but I do get some money, royalties from some patents that relate to some of the testing that I have, or the antibodies that I have discovered. So I want to kind of give you a little bit of an outline, because tests are only relevant if they're clinically helpful. And why are they clinically helpful? What do they actually assist you in doing when you see a patient who presents with a subacute onset of a complex, oftentimes multifocal neurological disorder? So I'm hoping in this brief time that we can give you some indication as to how understanding mechanism can potentially result in therapeutic decision making. So in other words, if you figure an antibody or identify an antibody, can it help you clinically in terms of what treatment you use? I want to get the concept of phenotypic overlap across and the idea that comprehensive evaluations have built-in redundancy so that you never should have to order more than one test. We have some physicians who are ordering 3 or 4 comprehensive neural antibody tests on a single patient, which is really wasteful of money and resources. I want to talk to you a little bit about how some of these antibodies can predict outcome and how they can help you in terms of your cancer search. And then I want to talk to you a little bit about how we are continually evolving and changing the evaluations, what's in, what's out, based on mainly the studies that we do. And then also I'd like to maybe address a little bit about the future of the field. So what is autoimmune neurology? The term autoimmune neurology was really put on the map at Mayo. We set up actually the first autoimmune neurology clinic. And more recently with Jeff Gelfand, we've got actually our own autoimmune neurology section at the AAN. And what you can see here is that when we talk about autoimmune neurology, we can refer to anything from cortex, I often say from cortex to colon. In fact, one of the talks I used to give years ago was that very concept, because we have patients who have autoimmune gastrointestinal dysmotility, where they have an autoimmune attack of the enteric nervous system of their gut. But you can see that there's a variety of different things here: encephalitis, seizures, movement disorders, polyneuropathies, GI dysmotility, myasthenia gravis, Lambert-Eaton myasthenic syndrome. And one of the main things about these conditions is that they're generally subacute. They often come on quite rapidly. They can be severe. They can be disabling. And when we talk about autoimmune neurology, we're basically saying that there is a specific antigenic target for the immune system, whether it's the target of an antibody that might cause a disease or the target of a T cell that causes the disease. And actually, autoimmune neurology, or at least if you look at encephalitis on a population basis, between 1995 and 2005, autoimmune encephalitis accounted for about a quarter of encephalitis, and it was much less common than infectious encephalitis. But now with biomarker discovery, we now know that autoimmune encephalitis actually is as common as infectious encephalitis. And given the fact that about half of what we presume to be autoimmune encephalitis is seronegative, we suspect that actually this is a 50% underestimate. So these are not uncommon conditions, and we really need to be thinking about them when we see patients coming into the clinic with subacute onset disorders. Now, obviously, my focus is antibodies, because that's what I've spent most of my career doing, is discovering novel antibody biomarkers that are present in patients' blood or spinal fluid. And hopefully at the end of this, we'll have a good sense as to why these are important and what they actually tell you as a clinician. But they're essentially antibody discoveries that occurred between 1960 and 1990, and you can see them here. These were the ones that I learned about when I was in medical school: the Hugh, Reed, the Yo, GAD65, the biomarkers for Lambert-Eaton syndrome, and the biomarkers for myasthenia gravis. But since 1990, there's just been a massive explosion in the numbers of neural antibodies that are now available in clinical use. Many of these will be very familiar to you. Water channel antibody, the first ever biomarker of an MS-like illness. We've got NMDA receptor antibodies discovered by Joseph Dalman, and then a host of other GABA and other types of antibodies that potentially are very relevant and indicate an immunotherapy responsive condition. And then there are many other antibodies that are more recent, GFAP, Kelch-11, neurofilament light chain, LUZP4, PDE10, all of these discovered at Mayo Clinic in the last few years. Now, when we talk about antibody evaluations, it's imperative that you understand what actually test is being done. So there are labs, for example, that are testing aquaporin-4 antibodies using ELISA, and that is not good. So you really need to know what is the test that the lab that you're ordering your test from is actually performing. Now, indirect immunofluorescence is very good for certain antibody detection, but not very good for others. And then generally, the field is tending to move away from Western blot analyses, ELISA, and even immunoprecipitation, more towards cell-based assays. And in fact, at Mayo Clinic, as you may know, we've developed live cell-based assays where we use flow cytometer analysis, and this has significant advantages. So just to give you an example, if you look at the water channel antibody testing, when we discovered the antibody back in 2004, at that time, we used an indirect immunofluorescence assay to detect the antibodies. And then over the years, we've very rapidly evolved. We've moved to immunoprecipitation assay. We then moved to a kit ELISA assay, which is still available in the US. We then moved to a Euroimmune kit cell-based assay. And now we use a live flow cytometer assay. And why did we move and why did we evolve? Well, we wanted to give you the best test. And as you can see, this is a study we did with Paddy Waters back in 2012, where we compared in a blinded fashion a variety of different assay methodologies. And what we found here, as you can see, is that the indirect immunofluorescence assay had a sensitivity of 48% in patients with NMO, whereas the ELISA was 60% and the flow cytometry was 77%. So far better than these other tests. So, for example, with ELISA, you're going to miss a lot of patients. And also, the positive predictive value in a recent study that we're currently under review for the Mayo Clinic live cell-based assay in Mayo Clinic patients is 100%. So that's kind of the ideal story. That's what we, as laboratorians, want to see for all of our assays. The reality, however, for other assays is not so good. So when we talk about the MOG assay, I want to just show you here, this is a blinded international collaborative study we did with Paddy Waters and Marcus Reindl. And you can see all the different labs here and all the different assay platforms. Some are cell-based assays, some are flow cytometry, some are ELISA. And then what we did was we sent positive patients and negative patients to a central lab where everything was blinded, labeled, and then sent to all labs for testing. And then we compared all the results. So basically, in the left column, this should all be black. Black means you're negative. And in the right column here, this should all be red because these were positive patients. Now, what you can see is that if you look at the top one, Innsbruck, their cell-based assay, and if you look at actually our one, Mayo Clinic here, you can see that we had basically 100% sensitivity and 100% specificity. So what I want to also show you, though, is look at the ELISA. If you look at the Anaspect ELISA or even the Euroimmune ELISA, you can pretty much see that you're basically missing the positives and you're picking up negatives. And essentially, the ELISA is the equivalent of a toss of a coin. So lots of labs will tell you that they do tests. They may charge you less, they may charge you more, but you really need to know what platform they're using and be aware of the literature because this is all published. Now, again, just to show you, we did some studies with our MOG IgG assay, and as I've shown you, it looks pretty good when it compares to other laboratories throughout the world in a blinded fashion. But actually, when we looked at the titer of the assay, for example, if you have high titer MOG antibodies greater than or equal to 1,000, then you basically have 100% specificity or positive predictive value for the MOGAD phenotype. But if you have lower titers of MOG antibodies, then your positive predictive value significantly reduces. So if you have lower titer antibodies for MOG, you have to really be careful in terms of how you interpret those antibodies. And you really need to interpret them within the clinical context. Obviously, we can always make a cutoff of an antibody titer to allow you get a 100% positive predictive value or 100% specificity, but then you're going to miss a lot of positive cases. Now, in addition, there are a lot of things that are changing. For example, traditionally, voltage-gated potassium channel complex antibodies used to be associated and indicative of an autoimmune neurological disorder, and many patients were treated with immunotherapy based on those antibody tests. But then it became evident that actually there were two targets within the complex, the voltage-gated potassium channel complex, that were relevant, and those were Caspr2 and LGI1. This was work from Oxford, our colleagues Sarosh Irani and Angela Vincent. And it turns out that only 15% of patients with voltage-gated potassium channel complex antibodies actually have antibodies to those specific targets, and those are clinically relevant, and those are very important. But for the other 85% that are negative for both of these antibodies, the antibodies in those patients are clinically irrelevant, and the antibodies are not pathogenic, and they're generally targeting proteins that are inside the cell. So what do? We've basically removed voltage-gated potassium channel complex antibodies from our phenotype-specific evaluations, and we just offer Caspr2 and LGI1 testing. Other tests and antibodies must be tested on platforms that have some complexity. So, for example, for this new antibody biomarker, which is actually quite common, the GFAP, autoimmune astrocytopathy, we generally want to test spinal fluid, and we generally will identify the pattern on tissue IF. And if we see that pattern, then we reflex to a cell-based assay. And the patient must be positive in on both assays to be considered positive. And this is the type of phenotype we see with that antibody. So when we think about antibodies, we've got antibodies that target nuclear or cytoplasmic neural proteins. And just a point here that's worth making, in patients who are undergoing comprehensive evaluations, the Hu-Re-Yo, which many of the older physicians will be very familiar with, account for less than 5% of the antibodies detected. So if you see a patient with autoimmune neurological disease and you're thinking Hu-Re-Yo, you are not thinking about 95% of patients. Now, these are antibodies in green that target proteins that are inside the cell, and there's a lot of them. And then we also need to think about, what does that tell us? So if an antibody is targeting a protein or an epitope of a protein inside the cell, these antibodies are generally indicative of tumor. So the classical paraneoplastic disorders, but some of them arise from a response to a virus or some other trigger. And what happens here is that these proteins are then presented, are brought to the lymph node by the dendritic cells and presented to the immune system. And basically you develop B cells that recognize these epitopes and pump out antibodies. And these are the antibodies that we detect when you send in the serum. And then the patients also develop T cell responses, as you can see here. Now remember that these antibodies that these B cells are producing, because the proteins are inside the cell, these antibodies are not pathogenic. They're just telling you that there's something going on, and they're telling you that there's probably a cytotoxic T cell mediated disease. These cytotoxic T cells then go back and fight the tumor or fight the virus, but they also then will travel around the body, and they sometimes will make their way up to the central nervous system. They can cross the blood-brain barrier, and they can travel around the brain or the spinal cord. And if they see that protein in the context of upregulated MHC class 1, they will attack and kill that cell. These conditions are very difficult to treat, but the general approach is identify the tumor, remove it, treat the tumor with cancer therapy, and suppress these cytotoxic T cells. And so the standard of therapy for many of these disorders is cyclophosphamide. Unfortunately, in the last 40 or 50 years, we've made very, very little advance in the management of these conditions. And also, these conditions are really coming to the fore now in the context of checkpoint inhibitor therapy for cancers. Now, the second type of antibody are the antibodies that target proteins that are outside the cell or on the cell surface. These are channels or receptors, etc. And how do they work? Well, again, generally, many of these are idiopathic, but some will develop in the context of tumor. So, for example, GABA-B in the context of small cell cancers, ovarian teratoma in the context of NMDA receptor encephalitis. Again, antigen presentation occurs at the lymph node. The B cells then are pumping out antibodies, specifically the plasmablasts, the plasma cells, and that might happen in the circulation peripherally. Generally it does, but sometimes it can happen in the intrathecal space, for example, in NMDA receptor encephalitis. And these antibodies are pathogenic. So, for example, they can turn on things and turn off things. They can activate complement and lesion cells. They can cause internalization or modulation of the target protein off the cell surface. And if you find one of these antibodies, it directs you towards, first of all, antibody depleting drugs or agents that potentially can benefit these patients. Anti-IL-6 drugs have had some potential benefit in patients with autoimmune encephalitis, NMDA receptor encephalitis being one of them, as well as MOG autoimmunity. And then complement inhibition is also another thing to think about. In fact, once you identify the biomarker and then you start to understand the mechanism of the disease, then you can actually end up identifying potential therapies that could have significant benefit for those patients. Now, this is a complex scheme, but this just shows you a little bit of the evolution of concepts and ideas that came from Mayo Clinic's aquaporin-4 antibody discovery, and then the work we did to try and understand and unearth mechanism, and then how that and how we and others then identified potential targets. And what you can see here is that it was recognized that plasmablasts would go up before a clinical attack of NMOSD. And at that time, IL-6 also would elevate. And so people thought about using an IL-6 inhibitor. The concept that rituximab was a good drug for this disease, but rituximab didn't really hit the plasmablasts. If you could identify a drug that could hit the plasmablast, maybe that potentially could benefit. So we were thinking about CD19 antibody-targeted drugs. And then obviously when the antibody, the aquaporin-4 antibody, binds to the water channel, it activates complement, and the complement kills the astrocyte or injures the astrocyte, and then also releases a very markedly inflammatory protein called C5a that essentially allows and attracts in this inflammatory process. And as many of you will know, we now have FDA-approved drugs based on randomized controlled trials that have been completed for satralizumab, for inebilizumab, and for eculizumab. So let's talk about encephalitis. So we have all these antibodies, but if your patient comes into you with a phenotype that doesn't fit with one of these antibodies, well, we wouldn't want to be testing for that antibody. So the concept of doing a comprehensive neural antibody test for every single antibody that you can imagine is wasteful and doesn't make any clinical sense. So what we have done at Mayo Clinic is we are beginning and have nearly completed a comprehensive phenotype coverall evaluation. So for example, here you can see this is an autoimmune encephalitis evaluation. And what we've done here is we've just picked the antibodies out that are pertinent to encephalitis or epilepsy or dementia or movement disorders or ataxia. And so these are the ones that are left. So these antibodies will be packaged into the autoimmune encephalitis evaluation. Now, it's also important to recognize that these antibodies can present very similarly in different patients. This concept that, well, I can look at a patient and tell what the antibody is, well, that's true in certain very rare situations. For example, if a patient comes in with facial-brachial dystonic seizures, then they probably have LGI1 autoimmunity. If they come in with a classic NMDA receptor antibody story, then potentially you can identify that antibody. But for most patients, it's not possible to identify the specific target antibody. And in fact, when we allowed physicians to order NMDA receptor antibodies on their own, 98% of the time, the patients were negative. And in fact, on the occasions where we actually tested those patients for other antibodies, we found other antibodies in a much higher proportion than we did for the NMDA receptor antibody specific test. So antibodies can phenotypically look very similar. In fact, many patients actually can have negative MRI scans and even normal spinal fluids. Also, patients can have very different outcomes, but have very similar presentations, depending on the antibody you do identify. So this is a female 74-year-old woman who came in with a progressive encephalopathy that was had rapid onset. You can see she had an inflammatory spinal fluid, and she was found to have AMPA receptor antibodies. That's what the staining pattern of AMPA looks like in the bottom right. And again, a limbic encephalitis that looked very similar to the other images I showed you before. She had a workup. She was found to have metastatic melanoma, but no primary. She was treated with appropriate chemotherapy and immunotherapy, and she made a complete recovery and is still doing well. Another patient, however, again, presented with a very similar presentation, but had a different antibody type, antineural nuclear antibody type 1. Again, a very similar neuroimaging picture. She was found to have metastatic small cell lung cancer, and unfortunately, she did very poorly. Now, obviously, you also have to select patients who you think are most likely to have the antibodies, because it's important that the pretest probability that you're going to find an antibody is high. Otherwise, you're going to be wasting money, but you're also potentially going to be identifying false positives, because if there's no test that's 100%. And here you can see this is a score that Dr. Dubé developed called the APE score, which allows you actually predict the likelihood that you're actually going to identify an antibody. And so the recommendation would be that you consider testing for antibodies if you've got an APE score that's greater than or equal to 4. And then we also developed a score that actually predicts, on the basis of the antibody you identify and other features, whether or not the patient will actually have an immunotherapy responsive condition. Now, what about other phenotype-specific evaluations? So movement disorders or ataxia. Again, there are certain antibodies that are not pertinent to ataxia that might be in the encephalitis evaluation. And so again, we take those antibodies and we package them into that evaluation. This just gives you an example of one ataxia-related antibody that we discovered at now. This is the pattern of staining we saw. These patients present with ataxia, oscillopathy, or vertigo, and they improve with immunotherapy. And work done by Dr. Andrew McKeown and Dr. Honorat identified that the target of this antibody was acceptin-5. In fact, we even went further, and Dr. McKeown investigated the potential for human proteoarrays to assist in novel antibody discovery. The original standard workup for this target took us about 6 to 12 months. But using a proteoarray, we sent 5 patient samples and 5 normal samples blinded to this company, where they looked to see if the patients had any antibodies bound to one of 9,000 purified human proteins. And their first hit for the 5 patients we sent, which was blinded, was septin-5. And this took 1 week. So I'll talk to you a little bit about progressive ataxia. The one that many of you will have heard about is PCA1 or anti-Yo in generally women who present with ovarian or uterine or breast carcinoma and ataxia. Unfortunately, generally the ataxia presents first, then the tumor is found, and these patients unfortunately have a relentless progression. The diagnosis is usually delayed for many, many months, and by the time they get to a center of excellence, they are already in a wheelchair, and it's too late. We obviously had an interest in the discovery of antibodies that are pertinent to ataxia, and we started to work with Dr. Joe DeRisi, Dr. Michael Wilson, and they had developed a mechanism of discovering novel antibodies to essentially the entire human proteome. So what they can do is they can take the human genome, break it into little pieces of DNA, put those into phage. The phage will then express the protein that's coded by that DNA. So you've basically got millions and millions of phages, all expressing different pieces of the human DNA. And eventually you've got essentially the entire human proteome that's expressed out on the surface of the phage. And then what you can do then is do a pull down experiment. So you mix the patient antibody with the phages, you do a pull down experiment, and then anything that's pulled down, you interrogate, you work back from the DNA to the protein, and then you can actually identify what the proteins are that those patients' antibodies are targeting. And this is a very interesting story. About 20 years ago, we started to recognize in the lab, very rarely, men who had antibodies that were binding to this mouse brain with these little sparkles, as you can see. And we went into the laboratory because we knew that the story was very important. These were all men. They all presented with subacute ataxia. They all became very disabled, and they pretty much all had testicular cancer. So we knew this was a very important biomarker. But despite our standard approaches to antigen discovery, we failed, and we were unable to discover this. And so working with Joe DeRisi and Michael Wilson, it's a long story, but it was published in the New England Journal of Medicine. They identified the antigenic target as being Kelch-11. And this just describes a patient with this disorder, 41-year-old man, developed hearing loss and imbalance, had an initial presentation of tinnitus, sensorineural hearing loss, intermittent dizziness, presumed viral labyrinthitis, treated with a variety of different treatments. 5 months later, again, it continued to worsen. Neuroimaging was normal. Spinal fluid showed a pleocytosis, so that would be a real indicator of an inflammatory process. And the patient had testicular seminoma found on ultrasound, and this was resected. And this was the work that we did with the DeRisi and Wilson labs. Here you can see all of our patients with this pattern had calcio-11 by phage display. We also looked at other patients with ataxia, including MA1 and MA2 positive patients. They were all negative. We transfected the calcio-11 target into cells and showed that there was co-localization of the antibody with that target. And so this was interesting. We also looked at the prevalence and found that calcio-11 in the Olmsted County population was actually quite high. In fact, one of the more common paraneoplastic neurologic disorders, completely missed up until now. These patients are generally diagnosed with progressive neurodegenerative disorders like MSA or PSP or cerebellar degeneration. Patients present with rhomboencephalitis. 16% will have limbic encephalitis. So remember, because 60% can have limbic encephalitis, that means that it has to go into the autoimmune encephalitis evaluation. Rhomboencephalitis means it has to go into the autoimmune ataxia evaluation. Hearing loss in 39% and tinnitus preceded neurological presentation. Well, we don't have a hearing loss evaluation yet. And then malignancies, you can see 79% of the patients had testicular cancer or microcystic fibrosis. So this is a male disease. If a man comes in with a subacute ataxia, this should be very high on your list. Now, while we were working to try and discover the calcio-11, because that took us about 2.5, 3 years, we went down a lot of rabbit holes, and Dr. Dubé was the fellow who is focused on this research and did all this work. But he went down this rabbit hole. We kind of pulled him out of the rabbit hole and said, no, let's get back and focus on the calcio-11. But once we figured out the calcio-11, back he went and made this, I think, wonderful discovery of another biomarker of and a different type of disease, but also testicular cancer, because we were looking at testicular cancer samples. And this is a new biomarker. This was just published in the Annals of Neurology, if you're interested. But and this is not available yet at Mayo, but obviously all these discoveries are things that are actively being worked in this beehive here. But hopefully we'll have it to you soon. Interestingly, I just wanted to show you that these patients can present with limbic encephalitis. They can present with rhomboencephalitis, but also interestingly, about 7% of the patients present with a motor neuron disease. So these patients actually look like motor neuron disease, but they're not motor neuron disease. They are a cytotoxic T-cell mediated motor neuron disease. And this just gives you some of the images of this atrophy with fasciculation and weakness that we see in some of the patients. And you can again see this in the Annals of Neurology paper. And remember that oftentimes the tumors are not identified in the testicle. Sometimes they've actually spread, and you actually identify them on PET scan in the chest. And this is a seminoma identified on a variety of different patients in the chest on PET scan. So always consider a PET scan if you suspect a paraneoplastic disorder. Now you can begin to see how the evaluations are beginning to evolve. You've got patients that can present with subacute onset progressive ataxia, but they could have PCA1 and have an ovarian or teratoma. They could be men with PCA1 and have a gastrointestinal tumor. They could be men with calcio-11 and have a testicular tumor. They could be men with CRIN5 or ANA1 and have small cell lung cancer. They could have a MA1 or a MA2 antibody, and those patients potentially could have germ cell tumors or a variety of different underlying malignancies. They could have mGlu1 or mGlu2, and maybe they have Hodgkin's lymphoma. Other interesting disorders here is a pattern of staining that we identified in the basal ganglia. This is work done by Anastasia Zakaridu. And interestingly, when we started seeing this pattern, this was quite recently, we contacted the physicians, and these patients had movement disorders. They had chorea, many of them. And interestingly, two of the patients were started on a checkpoint inhibitor, and we figured out what the target antigen of this antibody is, and it's actually PDE10A. And this is a new antibody, a new kid on the block. And obviously, we can still recognize this by its tissue pattern. If we saw it, we would obviously let you know, but it's not a validated test yet. So we talked about how these antibodies are packaged, what they mean, how they help us clinically, how one antibody can have a different outcome than another antibody, how the antibodies work, what they tell you in terms of mechanistic effects. But what else do they tell you? Well, they do tell you a little bit about cancer. So what about antibodies that are highly predictive of cancer? Well, these antibodies are highly predictive of cancer. In other words, if you find one of these antibodies either in the serum or the spinal fluid, then you know that the patients have a greater than 70 or 80% chance of having a cancer. So if you haven't found a cancer, you need to keep looking. And here you can see the likelihoods that these patients have cancer. But not only do they tell you that they have cancer, they tell you what the specific type of cancer is. So for example, if you have those antibodies, you know that you're really looking for a small cell lung cancer or a small cell cancer. And if they have these antibodies, then the likelihood of cancer is low, but it's not zero. So for example, if you've got GFAP antibodies, you've got a 25% chance of finding cancer. If you've got LGI1, it's less than 5% chance of finding thymoma. But if you've LGI1 and Caspr2 coexisting, which happens sometimes, then you've got about a 20% chance of finding a thymoma. And then there are other cancers that are associated with specific antibodies. For example, Hodgkin's lymphoma would be a cancer you would want to look for if you had a patient with PCATR or mGluR1 or mGluR5. And then thymoma, as I discussed, these are the antibody biomarkers of thymoma. So as we've covered a lot of antibodies, a lot of biomarkers. So what's the take-home message from all of this? So if you have a patient that comes in with an autoimmune subacute onset encephalitis, and you're thinking maybe it is autoimmune, or you have somebody that comes in with a subacute ataxia, and maybe you do a spinal fluid and it's inflammatory, and so you're saying, yeah, I really think that this could be immune-mediated, and you want to investigate and perform a neural antibody testing. If you just order a few of the antibodies and not the entire profile, you're essentially ordering half an X-ray. So you're ordering a chest X-ray of just the right side of the chest. If you do that, in many situations, you'll look at the chest X-ray and you'll say, well, at least if you're a neurologist, this looks pretty good. I don't have much to worry about here. But when you do that comprehensive evaluation, when you cover all the potentially identifiable antibodies that have clinical meaning, that have clinical significance, then the picture really changes. And you start to look and say, okay, there is something going on here. And in fact, in each of these different individual cases, there's something very different going on. That indicates a different diagnosis, indicates a different need for treatment, indicates a specific therapeutic approach, indicates a potentially different outcome. So at Mayo Clinic, we have developed the concept of disease-specific tests. And these are the evaluations that are currently available. We are continuing to work and develop potentially tumor-specific tests. So again, this is where our thinking is coming from. And I'm sure you've seen this concept of these antibodies as they get added in for the variety of different evaluations. Now remember that this is a moving target, because once calcium-11 is discovered, then it has to be added in. Well, it takes a long time to develop a validated test. So we have done that. And luckily, we're going to be offering calcium-11, I think it's offered now, as a standalone test. But it will ultimately end up in the autoimmune encephalopathy evaluation and the autoimmune movement disorder evaluation. As we discover antibodies, or as others discover antibodies, we bring them into the lab. We develop platforms or assays that provide you with the highest quality to make sure that when we detect the antibody, it means something. And then we package it into that evaluation and we offer it. And generally, as you know, when we add in all these antibodies, we generally tend to keep our prices the same. So you're getting a growing and growing and growing number of antibodies that is allowing you to feel more comfortable that you haven't missed something. The other thing to remember is that most of these antibodies we discover have a staining pattern on tissue. So we look down the microscope, and if we see that staining pattern, we contact the physician and tell them. We don't report it out because it's not a validated test. But if it's in development and we identify such a pattern, we will always communicate with the physician regarding the findings on the indirect immunofluorescence. Now, paraneoplastic evaluation is one of the traditional tests that our lab had. In fact, after myasthenia gravis and Lambert-Eaton syndrome testing, the paraneoplastic evaluation was the mainstay of neural antibody testing at Mayo Clinic. The paraneoplastic evaluation is being phased out. It's old hat. It does not provide a comprehensive and good quality evaluation. And as I pointed out earlier, the concept of having every antibody that's pertinent to paraneoplastic testing in one evaluation is not possible. So I would urge you to move away from this testing. And the reason is you're going to miss many things with this testing, because as we have updated the phenotype-specific evaluations, because we are phasing this out, we're not updating this. So please do not order this test. Once this is phased out, identify the phenotype that fits with your patient. So for example, if a patient presents with encephalitis, do the encephalitis evaluation on serum and CSF. If the patient presents with ataxia, do the movement disorder evaluation on serum and CSF. If the patient presents with an encephalitis and an ataxia, don't do both. Pick the most prominent phenotype and do that test. Never do more than one test, because there's redundancy built into the test. For example, if a patient can have ataxia and encephalitis, then that antibody, pertinent antibody, will be in both evaluations. This just shows you the phasing out concept. And as you can see at Mayo Clinic, as we continue to try and hit home the message of trying to move to phenotype-specific evaluations, we are making some headway at Mayo Clinic. Currently, we're kind of about the 70% mark in terms of ordering the phenotype-specific evaluations, but we have more work to do for our Mayo Medical Laboratory clients. So the take home from today is that neural antibodies often occur with a broad spectrum of neurological manifestations. Neurological autoimmunity can affect every level of the neural axis. The number of recognized antibody markers continues to grow, and it grows so rapidly that people that are not working in this specialty are not going to be able to be aware of all the antibodies or the implications of all the antibodies, and you're going to have to put your trust in the laboratory to provide you with that comprehensive workup. Both serum and CSF should be tested for neural antibodies, because some antibodies are best detected in spinal fluid and other antibodies are best detected in serum. And since you can't tell which antibody it's going to be, in order to be comprehensive, you've got to do both. A negative neural antibody result does not preclude an autoimmune diagnosis. When neurological autoimmunity is suspected, start immunotherapy even before the antibodies are available, because the standard of treatment for all of these treatments is the same. Intravenous methylprednisolone, 1 gram daily for 3 days or 1 gram daily for 5 days. Intravenous immune globulin or plasmapheresis. Conclusions: or comprehensive neural antibody testing is driven by discovery, complexity, and phenotypic overlap. And please note that a significant proportion of those discoveries are driven by Mayo Clinic laboratories, which is not only a clinical service laboratory, but it's a discovery engine, and it also contributes to the academic advancement and understanding of this disease. Neural antibody profiles provide the clinician with an important diagnostic tool in forming phenotype prognosis and etiology. It allows early diagnosis, allows therapeutic decision-making, it directs your cancer search, and it assists with patient and family counseling. Assays vary, as I've showed you, in sensitivity and specificity. So know your assay, know your lab, know the limitations. We will tell you the limitations. And in our reports, we will tell you that the likelihood that this is real is low or high. The likelihood that you're going to find a tumor will tell you the likelihood that it's autoimmune. Data-driven changes result in to our evaluation. So for example, if we discover something, we figure out that maybe this antibody isn't very helpful, we'll pull it. The complexity requires the laboratory director and neurologist knowledge of assay performance and specimen type. Remember, antibody clusters and signatures will provide us and you with data-driven interpretations, but you do need an expert to look at the evaluation. It's getting highly complex, and the evaluations and reports that are done at Mayo are done by clinical neurologists. So we're actually clinically seeing patients, and we're writing the reports that go out to you. And we're also available, as you know, to you to answer questions on a 9-to-5 basis daily at the clinic. And then order phenotype presentation specific evaluations, not the paraneoplastic evaluation. If you order the paraneoplastic evaluation, do not go home and sleep well. You have not covered your basis. Never order more than one evaluation on serum and CSF, and that will save your institution a lot of money, because we get many repeated orders on patients. So I think that's an important take-home message. And again, obviously, I work with a wonderful group of people, and not only all of the people that are working to try and help you get access to these tests, but all of my consultant colleagues, Vanda Lennon, who founded the lab. My co-directors, Dr. Andrew McKeown and Dr. John Mills here. He's our technical director and laboratory trained. And then we've got Owen Flanagan, who's the expert in myelopathy evaluations, Anastasia Zakharadu, who is our paraneoplastic diseases expert, Div Dubé, who's done a lot of our discovery, and he with Chris Klein really are focused on our peripheral nerve and muscle evaluations, which we are really building, and we hope to have the premier muscle and peripheral nerve evaluation soon. And then Dana Chance, who's a neuro-oncologist and is very much involved in a lot of the oncological aspects of the work we do. And then we've got this very big and growing development and clinical service laboratory. And we're very lucky to work with people that feel very passionate with the concept that the patient comes first, and everything that we do is ultimately oriented towards helping you make the right diagnosis and getting your patient as well as they can be. So thank you very much.